Greetings. My name is Symphony Roja Charles, student ID 0512500051. Will be presenting my abnormal psychology assignment presentation topic Reclaiming the Self. DID awareness in Malaysia. What is DID? To know furthermore, please follow me to the next slide. To begin with our presentation, DID is dissociative identity disorder. Okay, when you hear the word identity, it's about a person's character. It's a complex post-trauma condition. Post-trauma is something that has caused them to, in the past, that caused them this trauma. It has nothing to do with spiritual failing or character flaw. It's a biological, neurodevelopmental survival mechanism. Survival is a way the brain processes to survive. So the identity fragmentation here is like disruption of identity characterized by two or more distinctive personality states. Okay, they are marked continuity in sense of self and agency. Recurrent amnesia, gaps in recalling everyday events, so it takes time for them to process information, even personal information. Traumatic events inconsistent with ordinary forgetting. Okay, it's not like the common everyday forgetting which we used to say, oh, I forgot to water my plants. No, it's beyond that. The functional impairment here is symptoms cause clinically significant distress or impairment in social, occupational, other vital areas of functioning. Now, this is beyond what ordinary humans can able to do. For example, in workplace, so they will forget entirely about their workplace. So this is their level of trauma, too traumatized to even remember a daily occurrence activity. Cultural exclusion, the disturbance is not a normal part of a broadly accepted culture or religious practice. Now, this one many people could not accept because they feel that it is not a physical or mental issue, but it is more spiritual, so people tend to avoid. Scene 2, the evidence based pathway, clinical PSA framework, the theoretical foundation, structural dissociation, chronic trauma splits the identity into two, which is one normal part, which is the daily part, daily life, and we have the emotional parts where trauma defense takes place. Then we have phase stabilization. Safety and emotional regulation is a must, something that needs to be established when they are going through a recalling back some traumatic experiences in the past. Okay, therapeutic alliance, consistent, boundary focused relational security, repairs fragmented attachment system in DID patients. Okay, as we can see here, we have the clinical efficacy evidence of post-trauma symptoms and distress. See, the blue chart shows the pre-treatment baseline. Pre-treatment where we can see in 30 months, there's all the same, 100%, very high. The relative impact is 100%. Whereas for the post-treatment, as in after the treatment, so for PSD and distress, is gradually reduced from 62 to 39% here. Okay, we are all Malaysians. So let's look in our cultural perception, which is Malaysian cultural adaptation. Okay, we have the first here, which is collectivist family dynamics. Now, usually in families, it's difficult to accept such theories. So we have dissociation is viewed as attention seeking or source of familiar shame. Certain families think that if their child or an individual is acting up or showing these DID symptoms, it is not actually an illness, but instead it's a way of seeking attention, and it's something that is embarrassing to the family. But the psychoeducational model reframes identity states as neurodevelopmental survival mechanism. Okay, so it's their way of surviving their trauma, their mental way of surviving the trauma. Then we have the second tier, which is faith and spiritual beliefs. Of course, it's nothing wrong in believing in faith, but it shows that the challenges there is that it's misinterpreted as being cursed or being, as I put here in our Malaysian context, kena buatan orang, kena jampi lah. in common terms, it kena jampi, or spiritual possession, leading patients to bypass psychiatric care. So when this faith involves, they bypass, they ignore the psychiatric care that the individual needs and think it as a way for spiritual involvements to come in. So there's dual care strategy. So this way, how they're going to collaborate for this adaptation is that the family works with the collaboration of the individual's family with a psychiatrist and also the religious leaders. Like for Muslims, you have the ustads, the Christians, we have pastors and other mediums for spiritual comfort. Okay, validate faith without pathologizing beliefs. Okay, it's okay to have faith. So faith and also psychology working together. Then we have the third tier. The third way here is healthcare infrastructure. Okay, the healthcare is that the challenge here is that shortage of specialists and rushed consultation windows in public hospitals now, because there are too many patients and limited psychiatrists. So certain sessions will actually take more than it cannot be solved in a month or two, maybe 3 or 4 months you need to go through. So but due to constraint in people, in a specialists, so they had to like rush through the thing, and that brings the problem of solving the issue. So how to operational adaptation is get task shifting, integrate phase 1 tools into clinic kesihatan. So clinic kesihatan, they have the phase 1 where they basically talk it out and try to solve it. Reserve complex processing for tier hubs. Moving on to scene 4, call to action, which is healthcare professionals. So healthcare professionals should screen for dissociation in patients with complex trauma history. Of course, since we have restricted numbers of specialists, so screen the patients which are in critical condition and in dire need of attention. Look beyond the surface of treatment resistant depression. So do not look into this matter as a surface level issue, but look into deeper. Take the time and the effort to go deeper. Family members research further from when this incident started, how this traumatic incident started, and go into depth. So stop treating this trauma as a spiritual failure or clinical taboo. It's not a taboo and it's not a spiritual failure. It's nothing to do with spiritual, but it is more of a traumatic experience that has affected the human brain. Okay, of course, and we have a lot of care lines. For example, Talian Kase, which is 24 hours helpline, which people can reach out at any time. We have 15999 as the Talian Kase, the helpline, 24 hours. And we have also these Malaysian websites, Malaysian Mental Health Association, which is www.mmha.org.my. So this helpline is a place where people could reach out if you cannot solve it on your own. These are my references, and that is all from me. Thank you.